this is this week's stuff that you learned. I sort of went out of order. I'm going to do headaches first, and then I'm going to do the other two, and I sort of mixed them together. So the dementia and farm. Okay, headaches. So they're classified by primary and secondary headaches. So primary, there's no real cause. Like with anything, primary just means that it's the root of it. Secondary means it's caused by something else. So in the case of headaches, there's not really a cause. It's just idiopathic, and that's why it's a primary headache. There's many theories that he goes through each theory about why we have these primary headaches. Either there's a disturbance of the pain system or intrinsic sensitivity to stimuli, or is it vascular in some sort of way, inherited or acquired disturbances. So anyways, there's lots of theories of why we have this, but basically our types of headaches are going to be tension, migraine, cluster, and then trigeminal, which includes the cluster. Secondary headaches come from another disorder, like I said, and there's hundreds of different causes. Like you got hit in the head and now your head hurts, obviously. Your neck hurts, you've been studying too much, you've been bending down, you have bad posture. I mean, come on, go to OPP class and they're going to tell you that you've got some thoracic cervical dysfunction and now you have a headache. You've been drinking too much. You just took an exam, you drank too much, and now you've got a headache. Examples are going to be extracranial, so it's outside the brain, like sinusitis, otitis media, glaucoma, TMJ dysfunction. Intracranial in the inside is going to be vasculitis, dissection, central vein thrombosis, tumors, abscesses, meningitis. Moyamoya is an example. It's a type of vasculitis. Metabolic disorders are going to be retaining CO2. So think of somebody with COPD. They retain a ton of carbon dioxide. They're not able to breathe it off, which you'll learn a whole lot about in respiratory. Or maybe they have carbon monoxide poisoning. Okay, so migraines affect a ton of Americans. More are women. Migraines are higher, 10 times higher in those that are taking birth control. Actually, when I was on my OB rotation, one of the things that if a patient came in with birth control, there were multiple questions that you had to ask. And one of the questions were, have you had a history of migraines? And the patients don't know what migraine means. So you have to describe a migraine to them and ask if they've had this aura, or if they've had wavy lines. Do they have pounding headaches that last for a while? Do sounds or light affect their headache? And if they say yes, then maybe they can't go on birth control. Maybe they have to have the pills. Maybe they need to have something else instead. So that's something to think about. Before a menstrual cycle, women can get migraines. A lot of patients get their first migraine between age 10 and 30, and then the frequency of the attacks change per person because we're all different. Okay, so migraines. I liked this picture because it's kind of blurry, but it shows what a migraine kind of feels like. And I tried to include on all of these slides little sections from first aid. So a description of a migraine is throbbing. It's usually one-sided, and it's associated with noise and light sensitivity and nausea, vomiting. I really liked the mnemonic POUND. So pulsatile, last for a day, unilateral, nausea, and disabling. And that's something that you're going to hear on rotations too. I think doctors remember that. Is it a pounding pounding headache. That's a migraine. Sometimes they have neck discomfort, but not always. Triggers are going to be stress, menses, exerting yourself too much, withdrawing from caffeine, odors, food, certain types of foods, and certain drugs. Okay. Oops. We're going in the wrong direction. Okay. There's going to be migraine with aura and without aura. The migraine with aura is considered as the classic migraine. A migraine without aura is considered as a common migraine. So our classic migraine with aura accounts for not as many. That's why it's considered as classic and not common, 15%. And usually a visual disturbance is going to precede the headache before it begins. So I included some pictures just to show you like what this zigzag or spectra or schemata looks like, maybe to someone experiencing a migraine with aura if you've never done it. And you can also have the aura without the headache as well, which is kind of weird, but there you go. A migraine without aura accounts for most, 85% of migraines, and can be a recurrent headache from 4 to 72 hours. So the other thing that you need to think about when you're thinking about your differentials of migraine is going to be that a aura without a subsequent headache, if they have this aura and then then let's say that they become super confused and tired after the headache, you would also need to consider and think about a seizure. So that's not in the PowerPoint. I just thought that is like one of the things that, let's say you've got like one of your standardized patients, that might be something that they might have to keep in the back of their mind. Okay, so severity levels, we've got mild, moderate, severe, and status. So mild, they've got headaches, but they can continue, all the way to severe where they can't do anything. They've got to just lay there and they can't work. Status is one that is going to be lasting more than 72 hours. What about ischemia? Ischemia, yeah. So I feel like that, are you asking about like a possible differential for migraine with aura? Yeah, that would be an option as well. So principles of treatment, you can assess the extent and how like mild to severe it is with the MIDAS scale. But you can kind of just guess it, by looking at like what we did before, mild, moderate, severe, and status. So principles of treatment, we've got abortive therapy. So that means I've got a headache. Now I want to get rid of it immediately. How am I going to get rid of it? So the most common abortive treatments are, first off, triptans. I know I have it second, but they're the most important to know. Example would be like sumatriptan. They end in triptan. If a patient has a migraine, they may ask, like they throw you all these symptoms. How are we going to treat this? Because all of these different headaches are going to have slightly different treatments. So we've got that pulsatile, unilateral headache that gets worse with light. How do we get rid of it now? And the answer, first off, what do we start with is a triptan. Another one would be our ergotamine, which is not the best option to go for first. I would start with a triptan because these are bad in vascular disease. So if a patient has like cardiovascular disease or just any heart problems at all, or like peripheral artery disease, anything like this, let's not go for the ergos. It's also bad in pregnancy. And can't mix it with a triptan. So the answer is probably going to be triptan. Also, NSAIDs can help, but people typically take them a whole lot. So, symptomatic therapy, if a patient feels like they've got a lot of nausea and vomiting, antiemetics like promethazine or like even like Zofran, which is not on here, but that would help. Desterone, not great at saying that. That can help with those symptoms. Analgesics can help as sort of rescues, and then the non-drug osteopathic holistic medicine things would be like, let's do OMN, let's change our diet. If every time you eat a lemon, like, if there's lemon in your water, and every time that you have lemon, you get this terrible headache, well, maybe you should stop eating lemon. Avoid your triggers. Exercise typically helps. Regular sleep, avoid excess caffeine, don't stress. Easy for med students, right? Not stressing. All those things that you would think of that should help anything, that also helps nothing. Preventative therapy. So we're not looking to abort a migraine today, but we don't want to have a migraine in the future. So if a patient has more than 2 to 3 headaches a month, they can try beta blockers, tricyclic antidepressants, which are typically not used for antidepression anymore, anticonvulsants, or like seizure meds like topiramate or valproic acid, calcium channel blockers, and then they've tried all of this stuff and they still get migraines, so then they can start the expensive stuff that have only been out for like 5 years, which are the CGRP inhibitors that usually insurance doesn't want to pay for. But, and you can see commercials for them, like Amavig, Adjovi, Emgality, and Nurtec. And the top 3, these guys, just for information, are injections, and I think it's once a month. And then this last one is a dissolvable tablet, and people typically like that one. And then these have like site reactions, just so you know. Okay, also like non-medicinal therapies, again, avoid triggers, that all helps with prevention. And then Botox is another example, or is another thing that can prevent migraines. It really prevents like trigger or tension headaches more, but they also use it for migraines. It blocks substance P and again CGRP, like these inhibitors, and inhibits peripheral signals to the CNS to block central sensitization. Botox can be expensive. Also, you have to get it every 3 months. It's just like if you got it for your face. Again, like it's the same. Like you have to. It's not like one and done. You have to get it every so often. And they get it on the top of your head and the back of your neck. So lots of injections. Tension headaches. So I feel like these headaches would be common in medical students. It's kind of a chronic pain syndrome, bilateral, bands-like, I totally spelled like wrong, but that's okay. Bands-like type discomfort. So guys may not like think about this as much, but like if you're wearing a headband, especially those that are like the stretchy kind, I can't wear a headband and they make my head hurt. And it's sort of like a tension headache. It's that tight pressure that just creates that bilateral circle around. So they're either episodic or chronic, and they don't have those migraine pound features. No nausea, no vomiting. Light doesn't affect it. No aura. So it's not going to be unilateral. It's bilateral, and it's that pressure tightening, and it's not aggravated by your routine. So treatment is going to be our analgesics, like our Tylenol, our NSAIDs, relaxation, and then remember, don't take your analgesics like every day, so then you can have a rebound. and then also TCAs as well. Okay. Cluster headaches. I think these are pretty cool. They're one of the trigeminal autonomic cephalgias. This is the most important one of those TACs that I would know. It's periodic. It lasts 30 to 90 minutes, and it's going to be located behind an eye, temple or forehead or cheek. It's more common in men, and then you get these like really cool, they're not that cool, I guess, but like you get these cool symptoms that are like the SPLED symptoms. So you get tearing, ptosis, nasal stuffiness. You're thinking like all on one side. It's almost like, what in the world is going on? Does this patient have Bell's palsy? Are they having a stroke? What happened? It happens usually every single day at the same time. So like every day at 10 a.m., this person gets all these symptoms for like 30 minutes. And it'll come in a season, so they may have it for months, and then it all of a sudden goes away. Sometimes it'll wake them from sleep. It's common in smokers, and it could be triggered by alcohol as well. And they can be chronic in nature. And these are really bad headaches. Sometimes people say that these are worse than migraines. The reason why I think these are pretty cool is that the therapy is pretty awesome. So our therapy is going to be oxygen. You give this patient with a cluster headache, they're like tearing up on one side, they've got a terrible, terrible headache. You put them on oxygen and then they feel better. Okay. So the only thing is about oxygen is that insurance doesn't pay for it. So that's like the sad news, like for some reason, like that would be like the best option. Steroids can help, triptans can help, and as well as analgesics. But if it's asking you a question, I would say oxygen. Again, like the triptans. And then we're going to prophylax against it with verapamil. So somebody's got a question about tension headaches. So let me go back. So yeah, you can have photophobia or sound phonophobia, but you're not going to have both of them. But like what I want you to think about is when you have a tension headache, more than likely you're not going to have phonophobia or photophobia or aura. Just kind of separate it in your mind, because if you start like mixing them all up, and you can have some of the features of migraine, and sometimes the test questions make you think it's going to be a different question. I mean, a different migraine than it should be. But try to separate it and think this is more like pressing bilateral, more than associated with the migraine symptoms. Does that make sense? Okay. Yeah, you definitely can have other symptoms, but more than likely you're not going to. And like when you get a test question, sometimes you get a question and you're like, it literally looks like, and I remember like getting a SPE and they all look the same, and they want you to kind of be a little bit confused and have like different symptoms of multiple different headaches, because in real life, people aren't, they don't read the textbook before they come in, and they have all different symptoms. But try to keep it straight, like, okay, this patient has several of these features. They have they could have two headaches going on, but like on a test question, you're gonna have one headache going on. And they have mostly, let's say cluster, they have mostly cluster symptoms because they're tearing and they have nasal stuffiness and they've got some ptosis going on. They may have these migraine symptoms, But the fact that they've got all of these autonomic features or whatever, and it's located behind the eye, makes me think it's more cluster. So kind of like do a little checklist in your head and say, okay, most of the symptoms look like this headache, so that's probably what it is. And they're probably gonna like ask you a treatment question because the treatment is different for all of these pretty much. So how do we abort a migraine? Triptans. How do we abort a tension headache? We're going to like do more analgesics, NSAIDs. It might be like neck tension is started our tension headache, and neck pain. So let's get rid of that inflammation using an NSAID. How do we abort a cluster headache? The best way is going to be oxygen. So that's probably how I'll ask these questions. Let me make sure I know them. Okay. So again, like the rest of cluster headaches, calcium channel blockers, valproic acid, topiramate might help. Again, avoid triggers, and then, but calcium channel blockers are going to be our prevention. So migraine prevention, we're starting with beta blockers. Cluster headache prevention, we're starting with calcium channel blockers. Okay. So then he goes into these other types of trigeminal autonomic cephalgias. I honestly I don't feel like these are important, but I wanted to just include his table instead of going through all of them because I really think that cluster headache is the most important, and that's really the only one that you would see on boards. You're not going to see any of these other ones after this lecture, probably ever, unless you're a neurologist. And because they're very similar. So cluster headaches, like attack frequency is going to be like one and alternate days. Paroxysmal hemicrania is going to be 1 to 40. And then SUMPT is going to be 3 to 200 per day. The duration of attack is going to be really short for the paroxysmal compared to the other two. The cluster headaches may have migraine features, you know, as we talked about, sometimes things crisscross. They all three have migraine features. Alcohol triggers clusters, but doesn't trigger the other two. Abortive treatment and prophylactic treatment is different. So we said oxygen for cluster headaches. For some, it's going to be IV lidocaine, which is kind of weird. And then prophylactic treatment is verapamil for cluster headaches. It's indomethacin for paroxysmal hemicrania. And then more of our seizure meds, lamotrigine, topiramate, and gabapentin for some. The longer version, it looks pretty much the same of the paroxysmal hemicrania, is going to be hemicrania continua, so it just makes it sound like it continues for a longer time, and it's treated the same with the indomethacin. So that's the other two. I really think if he's going to ask a question, it's probably going to be a cluster. That's my taking the guess. So here's some other important headache causes that are not in the lecture, but I feel like you should know them in the future. So I'm just going to pass by them, but you have them for your notes. So also, I don't know why I just included a bunch of like dolly paintings. So through these. Okay. So that's the headache lectures. Any questions? And again, for those who join later, I have my number on the first slide, and I have my entire drive. I've got farm guides, and one of them will be in here. But I have like guides for everything. If you have any questions at any time, like please text me, message me, email me. Like, I really don't care. Like it could be about any class. It doesn't have to be about this. It can be about like your life. questions. I mean, even if it's like at the end of the year or next year, it's really fun. Okay. Mild cognitive impairment. These are going to be the at-risk people that are going to develop dementia. So it's like our pre-dementia. So basically, like, let's say that you're 50 and a 50-year-old should be able to find their keys. And if they can't, then that is sort of a problem. If they can't remember to do their normal tasks, and then it's an issue. Side note, you know, we all get sleepy, we all get stressed, and there are times that like we're studying, we're trying to like do too many things at once and we can't find our keys. Like, don't worry, it's not mild cognitive impairment. It's probably that you just like need to drink water and do all those like fun things and like get good sleep, and then you won't be cognitively impaired. So it's like there's my keys sometimes too. Dementia. Is it going to be impairment in functioning, including memory, reasoning and judgment, visual spatial perception, language, personality, and behavior? It's important to know that it's a progressive decline. It's not rapid, and it's not associated with anything else. And why I point this out is the next slide. Is this the chicken or the egg? And so we've got delirium, dementia, and pseudo-dementia. I feel like on rotations, every single time, I always say, if a patient has dementia or delirium, I say, let's not forget about depression every time. Like, I'm like, it could be pseudo-dementia. So when you're in psych, you're going to learn about pseudo-dementia, and basically it's depression. You get all the depressive symptoms that you'll learn about, and one of the things is going to be, which the mnemonic for learning depression is the sticky caps, and we'll learn about that. But the first letter is telling us that it could be a cognitive impairment and pseudo-dementia. So if a patient presents with depressive symptoms, or they live alone, it's COVID, they can't go out, they're not eating right, they don't know why they're living. Think about pseudo-dementia. If we treat the depression, their dementia goes away. It's kind of fascinating. Delirium is going to be acute. It's not progressive like our dementia was. And it's going to be a fluctuating, confused state. So another thing that's absolutely wild, when patients go into the hospital, they get sometimes hospital or ICU delirium or psychosis, and they have no idea where they are. They have no idea what day it is. They completely lose it. Sometimes they go crazy at night. They're like throwing things, cursing, and it's like these sweet little grandmas that never would do that. And that's what delirium is. It's acute. As soon as they get out of the hospital, like all of this goes away. So it's kind of crazy. Dementia, we can't treat them with depression meds. We can't take them out of the hospital. This is a progressive decline of impaired memory, language, reasoning, and personality. Okay. Our favorite is going to be Alzheimer's. So I included the first aid at the top. And we can see on MRI that it's going to be like bigger sulci, gyri are farther apart. Going back to what we knew before from last test, remember like tau protein, beta amyloid sheets, associated with age, vascular disease, toxins, ApoE4, those plaques and tangles. Just remember all of that, associated with low ACH receptors. And then it's that dysregulation of serotonin and glutamate. And this is going to be some of our targets for treatment. Even though we don't have we can't cure it, we can treat the symptoms. So, or semi-slow it down. Remember the association with Down syndrome. They can get early onset Alzheimer's. Okay, so management. I think this was cool. It was from your lecture. This guy, he drew himself at the onset of being diagnosed, and he would continue drawing himself, and you can see how, as time went on, all the way to the end, he doesn't look at all like himself. So management is going to be ACH uh, inhibitors, so like cholinergic drugs. So donazepam is going to be our most common one that we think about, and we're inhibiting acetylcholinesterase. Our side effects are going to be like SLUD, and then we're going to have like low heart rate, a high blood pressure. They could have peristalsis, nutrition, contraction of muscles, so like respiratory paralysis, cold, pale, their potassium would be high. And then drug interactions could be with beta blockers. So beta blockers decrease our heart rate. These drugs also decrease our heart rate. We don't want to have like super low heart rate, so that makes them not good to put together. And then antimuscarinics as well. They kind of like offset the action of our acetylcholinesterase inhibitors. So I included a portion of OMS 1 year PowerPoint slide that I made from Dr. Babos' lecture. So you can see how like our PNS, SNS, and somatic, how ACH is used here. And so if we're inhibiting the reuptake, we're going to have more acetylcholine available. Okay, targeting glutamate is going to be memantidine, and it is a NMDA receptor antagonist. It's going to require coactivation by glycine and glutamate, and opening of the channel allows sodium and calcium to come in. So it's considered an excitotoxin. It's use dependent and an antagonist of the NMDA receptor. Side effects are going to be increased blood pressure and headache. For treatment, ginkgo biloba is something that would be over the counter, but it can cause increased bleeding. So a patient with Alzheimer's may also have like a bunch of other things going on, and maybe like on warfarin or something. So that's not good. And like if they're on seizures, ginkgo biloba can also cause that. Okay, vascular dementia. So we had talked about that just a little bit. So it's going to be caused by ischemic hemorrhagic injuries as a consequence of cerebrovascular or cardiovascular disease. So if you think about vascular dementia, think about strokes. So if a patient has had a stroke, you read this long stem and it says something about the fact that they've had a stroke, or like, let's say they have AFib, and then they started developing all of these brain symptoms, then this could be a vascular dementia. So think about anything heart or brain, or stroke or heart issues. Start thinking about, okay, it could be vascular. Multi-infarct dementia, which is shown in this picture. You can see all these little hyper-intense lesions, and that's going to be our recurrent strokes. And then Biswanger's disease is going to be diffuse white matter disease and lacunar infarcts. So we would see like lots of white. He had those red, so I feel like they're red. And here's the little case. So with the rest of these, I started including the case just on the side that he had from his lecture, just so that you have like an example of what it could be if he asks the question. Frontotemporal dementia, which is also called Pick's disease, is primarily consisted of a language deterioration or personality before the memory loss and dementia. So make sure that you know that. A patient who, like, let's say, did everything right, was really sweet, gave to charity, donated their time, made cookies, so, I don't know, something like they were really nice, and then all of a sudden they become like me, and they're yelling at people, hypersexual, they're things that they would never say are now saying, and then they start developing some memories. That is Pick's disease. The illness is going to progress for years, and if we get imaging, we're going to see a lobar atrophy of the frontal or temporal lobes. So we can see right here, we've got more of the sulci and less gyri, and that's in our temporal region. And then right here in B, we can see more of the frontal. We have more space. And here's our case. Lewy body dementia is going to be sort of associated with Parkinson. So it has those classic Parkinson symptoms plus dementia. It's the second most common cause of dementia after Alzheimer's. And our symptoms are going to be our cognitive rigidity, bradykinesia, postural instability, shuffling gait. That's all of our Parkinson symptoms. Plus, we're going to have our dementia. They may have hallucinations. They could have REM sleep disorders, or just that memory decline as well. And so a way of remembering hallucinations is Lewy hallucinations. That's our Parkinson features. And the Parkinson features, you can remember traps, tremor, rigidity, amnesia, postural instability, and shuffling gait. On our brain, it's the hummingbird sign. And so if we look at our brainstem right here, we can see it kind of looks like a hummingbird. So I colored it in so you could see it just. And then we've got some like cerebellar atrophy. So things that contribute to Parkinson's are going to be, again, our like alpha-synuclein gene. Remember from like our last test, like 2, and then toxin exposure like dopamine antagonist. So how do we treat this? It's going to be levodopa and carbidopa. So L-dopa is the precursor. This is one of our treatments. It has facilitated transport through the gut and through the blood-brain barrier. And the problem with levodopa is that it goes through the blood-brain barrier. It affects our brain, but then we also have all of these peripheral side effects. Well, we don't want that. So instead, we want to add carbidopa to it, and all that carbidopa does is it's going to get rid of the peripheral side effects. So basically, it just stays in our brain. So Cinemet is the brand name for that. Okay, so B6, protein and iron can interact with it and decrease absorption. It also can increase arrhythmias, and combined with the MAO inhibitor, which honestly, like MAO inhibitors, like can cause all sorts of bad things. You need to watch the cardiac function. So side effects are going to be peak dose dyskinesia. So the patient may have to have more and more, and then they start developing this dyskinesia, which I think I'll slide on later. Or here. So they can have chorea or apoptosis that occurs because it's reducing how to fix it is to reduce the dose or add a COMT inhibitor with a lower dose, or like change them to something else instead. All right. I think I've got a slide. I've got another slide on more treatments. And I think I didn't put them side by side. So okay, we'll go on and then come back to more treatments. So normal pressure hydrocephalus is one of these causes of hydrocephalus and has a triad of dementia, gait instability, and urinary incontinence. So if you've got a patient that, again, has not had dementia for years and years and years, but just comes in all of a sudden, like they just can't walk right and they're peeing on themselves and they start and then they start forgetting. It's not, they forgot things for years and then start peeing on themselves or can't take care of themselves. Instead, all of these things sort of happen together that occur over weeks to months. Then start thinking about normal pressure hydrocephalus. We get a picture and they've got ventricular enlargement. And so how do we treat it? It's going to be therapeutic lumbar punctures to remove CSF. So one of your classmates texted me this week and it was asking me about LPs. So we had this discussion and then I figured out with problems. Lumbar punctures is what this LP means. So a lumbar puncture is where they take a needle and insert it into the spinal canal and draw out fluid. So think, like, remember, we're going through, we're going to go like where the cauda equina is located. So you go through the dura mater, and then we're in the arachnoid space. Then we get to like the arachnoid mater, and then we get to like pia mater is, remember, on the spinal cord itself. So we're going into that arachnoid space and we're removing fluid and moving CSF. And so basically you just let it leak. Then you take the needle out and we're done. That's what an LP, a therapeutic LP. There's also something called LP shunt, and that is where, that's like the shunt that's in your brain, like for like ventricular, and then it drains down to the peritoneum. That is a VP shunt. Well, LP shunt is where it's from your back and it drains to your belly. So I just thought I'd explain it just in case you were confused. Because it gets confusing when everything's the same letters. It means similar things. So this is a lumbar puncture. Just so you know. Okay, Creutzfeldt-Jakob syndrome. The infectious version is called mad cow disease, and it is a rapid progressive prion disorder with focal cortical signs. So it is a progressive dementia with personality change. Oh no, personality change. I thought we were talking about Pick's disease with that. Think of this more as a longer or progressively demented, and they get the personality change. Also, they can have the myoclonus, so if they're startled, they can exhibit that as well. And death is going to be less than a year, so it's really quick. So think about like gait problems, behavioral problems, and like jerky hand movements. So I didn't like, should have written it right here, but you write it down and put, you know, the myoclonus is also something. Okay, so here's some toxic syndromes that I don't think they went over, but it's just good to know, so I just included this in here. Okay, so dystonia, this is that patterned directional movement, that lack of dopamine. So that's when we were talking about our Parkinson. And so we've got an excess of acetylcholine. So it's that chronic use of dopamine antagonists like carbidopa. levodopa-carbidopa. Dyskinesia is going to be that access or excess, sorry, of dopamine, like in Huntington's, which is also a side effect of our dopamine agonists. Okay, so here's our dopaminergics. Dyskinesia is more common with our levodopa, and we can also have nausea, orthostatic hypotension, and dysrhythmia. I think she went over MAO-B inhibitors like sledgeline or dopamine. A big thing of sledgeline and MAO-B inhibitors are going to be risk of serotonin syndrome. And that's why it's important to like this. So here's our serotonin syndrome. We've got agitation, diaphoresis, diarrhea, hyperthermia, hyperflexia. One of the things that I remember is clonus. So I think of everything hyper with serotonin with our versus like some of our other ones. I just included Huntington's disease just for you. There's no need for that. Okay. So looking kind of at all of these, we have got oh, I included the wrong PowerPoint slide. Just X this out and I'll be ready. Anyways, do you have any questions? Here we go. There's Parkinson's versus Alzheimer's versus Huntington's. So Parkinson's worsened by anti-dopamine drugs like haloperidol, metoclopramide. And then remember with our treatment, like our dopamine agonist, carbidopa, levodopa, we can have our peak dose dyskinesia. Also know things like ropinirole and pantoprazole are going to be dopamine agonists, and they also can be used to treat restless leg syndrome. Neuroleptic malignant syndrome is a cause of an abrupt stopping withdrawal of dopaminergic. And then our MAO-B inhibitors have a risk of serotonin syndrome. Alzheimer's can be treated with our they occur with antimuscarinics treated by acetylcholinesterase inhibitors like donepezil. And then, so don't give our muscarinic blockers or like our tricyclic antidepressants because they worsen. Okay, that's the right exercise. Now like fix it and reapply. Any questions?